Welcome to Healthy Heart. This is Dr. Isaac Opoku-Asare. Thank you very much for joining me this evening for another discussion. And I want to thank our producer, Mr. Blay, who has been doing a great job. And I believe that all of you can ascertain that our production has been much better this year. And I think it's coming from the great work that he's doing. So we appreciate the good work he's doing, and we also appreciate all our listeners. Hopefully, you'll be able to invite more people to join us even as we carry on this important discussion. The question is, why is healthy heart important? Because when you look at the causes of death, the number one cause of death in the whole world, in this country, is related to the heart. And death from the heart is more than all the cancers and the pulmonary diseases put together. At least some data a few years ago showed that. So that is why when you take care of the heart, you take care of a major component of your overall health. And that is why a healthy heart is important. And today we would like to continue our discussion about coronary artery disease, which essentially stands for blockage in the blood vessels that goes to the heart. And we did a discussion last week about what are the symptoms, how do people present more or less, and we show you the graphics. So unlike a clot, which is made up of platelets and other things, when we talk about coronary artery disease, which is, let's make it simple, CAD. Doctors say the person has got CAD. As we showed you last week, and we're going to show you the picture again this week, it's essentially the layering of plaque, which is made up of calcium and the bad cholesterol, which is LDL, in there. So we talked about the concept that once one LDL gets there, it gives room for more of them to come over there. And that we show you the graphics that that by the time we start around even 20 years, the plaque starts laying down in the blood vessels. And by the time that most people get to 40 years, especially for men, there is enough blockage that is already going on there because of the plaque that is made up of cholesterol and macrophages and other things. So most people, whether men or women, by the age of 50 years, they have these plaques that have been laid, and that is coronary artery disease if they have been laid in the blood vessels. We'll come and talk about peripheral vascular disease, and we'll talk about venous disease at a later time. So why is that important? The reason why this is important is that sometimes you may have a blockage of 40%. You went to your doctor, and your doctor said everything is good. Why do people get heart attack? The fact that you've got a blockage in your heart does not mean that you've got a heart attack. This is the principle of a heart attack. That the heart attack occurs because there's been damage to the blood vessels, to the muscles, the heart muscles, and what we call myocardial infarction. That is the definition of heart attack. CAD, which is coronary artery disease, implies that there are plaques that are blocking the blood flow to the heart. But what is the relationship between the CAD and the heart attack, which is myocardial infarction? I want to bring some clarity here. Coronary artery disease means you've got plaques in the blood vessels that is reducing blood flow to the muscles of the heart. When you have a heart attack, in that case, you have suffered damage to the muscles, and generally, if it occurs suddenly, the reason why this can happen in most people is the fact that you may have a blockage of about 40 or 50%. And you're all right. But most of the plaques that are in the body is covered by a layer of calcium sometimes with macrophages. And what happens is that that plaque can rupture. The covering of that plaque can rupture. And when it ruptures, and the components of the plaque, they are not supposed to come in contact with blood. When they come in contact with the blood, then they can form a clot on top of it immediately. And that's what causes heart attack. And that is why somebody can be walking around, he says he's completely okay, he does not know that he's got coronary artery disease. That is, he did not know that he had a plaque. And even if he had a plaque, at that time there was no problem. And then all of a sudden you can start complaining of chest pain, and that is what can lead to heart attacks. The other component of coronary artery, so not all coronary artery disease are heart attacks, but it is what leads to heart attacks. Because, and especially it's not the people with the 90% blockage, it's the people with 40%, 50% blockages that can have a massive heart attack. I've seen a wave of heart attacks since the coronary artery, since the COVID started, and it is pretty interesting. In other places, it hasn't been that way. And I've seen it in the relatively young people, and most of the people that I've seen, they are in their 40s and in their 50s, and I'm sure that they did not know that they've got such blockage even in their heart. So even in the blood vessels in their heart, I want to clarify that. This is a very, very important distinction that we're making here. So why is it that it is important for us to talk about coronary disease? Every 40 seconds, I'm repeating this, every 40 seconds, somebody in the United States of America, he gets a heart attack. By the time that I finish this discussion, by the statistics, right, if this discussion is going to go on for 45 minutes, just think about it. Every 40 minutes, somebody gets a heart attack in America. So within an hour, just do the calculation for yourself, right? Within an hour, somebody gets a heart attack. And within a day, somebody gets a heart attack. And the reason is that there's so many people. Because the risk factors of coronary artery disease, as CAD is so common, a lot of people have CAD and they don't know. And that is why this is important to have that discussion, right? And take the appropriate steps, because in controlling the factors that are there, that is going to help you. So that is why this topic is very, very important. I'm repeating this. Every 40 seconds, somebody gets heart attack in this country, not in the world. And that is why you would like to know this and take the appropriate steps to be able to address it. So I would strongly encourage you to go and look and listen to our video that we did last week that talked about, that showed you what a CAD is and also showed you how you are presenting. And if you have those symptoms, it's important that you check with your doctor and it is appropriately addressed. So we talked about the symptoms, so we're not going to go through that. And because today the emphasis is how do we diagnose? How do we diagnose that somebody has got coronary artery disease or not? So we talked about it, that the classic presentation is either shortness of breath or chest pain, right? Or people don't usually even have chest pain, they have pressure, right? And if you have chest discomfort when you walk and you stop, the chest discomfort goes away, you really need to check it with a cardiologist or somebody like that to make sure that nothing like that is nothing, to make sure that you rule out coronary artery disease. Because as the blockage gets tighter and tighter and tighter, one of the things that it does is that it reduces blood supply, and ultimately it can make the heart weak. So even if you don't get a heart attack, because of the reduce, it's like not eating for a very long time. The heart will ultimately be weak, and that is why it needs to be checked. So how do we know? So for instance, you go to your doctor, and when you go to your doctor, you're going to tell your doctor, okay, when I walk, I get chest pain, and when I stop, the chest pain goes away. I get chest pressure, or I've been having shortness of breath, and when I walk, they need to rule out the other component and other causes of shortness of breath, which we're going to talk about it later on in terms of that, in terms of the other causes. But let's say that your doctor did an assessment, he listened to you, and the first thing that your doctor will do is an EKG. The EKG will give us an idea whether you had a heart attack in the past, or the evidence that you are having what? There may be some blockages in the heart, in the blood vessels going to the heart. So it always starts with the EKG. Let's start with that. So once we have the EKG and the EKG is abnormal, then that will determine the kind of test that we're going to do. So if the EKG is normal, then most doctors, and the recommendation here is the fact that they should do what we call exercise stress test. So what is exercise stress test? You see, whatever, when it comes to the heart, everything, I mean, not everything, but most of the things revolve around what? Exercise. So if your EKG is normal, then what the doctors, most cardiologists would do is what we call exercise stress test. So the stress test is not about like the fact that you don't have money in your bank accounts and you are worried. I asked a patient that you need a stress test. He said, "Dog, there's already too much stress in my life." I said, "Yes, stress is part of living in America, right? And I think it's part of life everywhere you are, not only in America, but everywhere you are." So what does the stress test stand for? So it is supposed to test and see that under appropriate physical activity, does the blood flow to the heart get compromised or not? So as you see in this picture, you're going to see that there's somebody that is running on a treadmill, and there is electrodes that are connected to the person, and there is a monitor that the doctor is looking at. So and you see the person also watching his watch. The way it is done is the fact that you are supposed to run on a treadmill, and as you're running on the treadmill or you're walking on the treadmill, we increase the speed and the slope of it as you go on. And generally, it is known, we expect that you should be able to increase your heart rate to a target of 220. So everybody, your target heart rate, minimum of your target heart rate, should be 220 minus your age. And 85% of that is what we are looking at. So I'm repeating this, 220 minus your age. And that every figure that you get, that should be your maximum heart rate. That is what we're looking at. It's not maximum heart rate, but that is the target heart rate. And once you're able to get 85% of that, then you have achieved your target heart rate. That will make the exercise stress test something that a doctor can use to explain whether at that time whether there is evidence of reduction in blood supply to the heart. So generally, the longer you are able to run on a treadmill without having chest pain, the better it is. And the longer you go, for instance, if you're able to go on a treadmill, and a lot of my patients come to me and said, "Oh, I've been doing exercise at home. I've been running on a treadmill." Some people run on a treadmill at the pace of a snail, right? That is, I tell them that is going to be different, because most people, they do what? They do the exercise without a slope on it. But in our case, we add a slope. Every stage we increase the speed and we increase the slope. So the addition of increasing the speed and the addition of the slope makes the workload even higher. And that is why if you can really be on a treadmill for during an exercise stress test for about 12 minutes, that is excellent, and that will give you something we call metabolic equivalent. So the doctor will also going to look at the EKG during the time that you're exercising and see whether during the time there's evidence on the EKG that you've ended up, you have what? The blood supply to the heart is being compromised by your physical activity. So that is what the exercise stress test is supposed to do. So you see, it shows that engaging yourself in physical activity goes a long way, because even the cardiologist that is supposed to test you is testing you based on what? On your exercise capacity. So that is why exercise is very important. So when you do the exercise stress test and it shows, the doctor tells you that the exercise stress test is normal, what he's trying to tell you is not that there is no blockage in your heart. That is a misinterpretation. What the doctor is telling you is that, as based on the knowledge that we've been able to get from the exercise stress test, it tells us that the chest pain or the shortness of breath that you're having is not coming from reduced blood supply to your heart. You may have a plaque in the blood vessels, but they may not be severe enough to cause a reduction in the blood supply to the heart with physical activity. So that is the meaning of a normal stress test. So a normal stress test does not mean, I'm repeating this, a normal stress test does not mean that there is no plaques in in your coronaries. No, what it means is that the symptoms that you're having as at that time is not coming from a reduction of blood supply, right, to the heart as a result of the plaques that are in your coronaries. So this is something that even confuses certain doctors. They said that the stress test was normal, and because the stress test was normal, this means that there's no plaque in the heart. No. And that is why I've kept on repeating this part. Very important. So sometimes you go to the doctor and your EKG is already abnormal. The EKG may show that you had a lot of people have what we call silent heart attacks, and they don't know. They had a heart attack and they don't know. The EKG can show us that you had a heart attack some time ago and you didn't know. And it's okay. I mean, it's okay from the concept that you are alive now and you're sitting in front of a doctor and we can do something about it. So if your EKG is abnormal, and that is in the realm of the cardiologist or whosoever is taking care of you, I personally believe that if you're having chest pain and you're worried about blockage in the heart, that is something that needs a cardiologist evaluation, because that is where the expertise is. So in that condition, in that situation, if the EKG is abnormal to start with, then there are other stress tests that the doctor can consider. And there are also stress tests, but one of them is what we call nuclear stress tests. So in the case of the nuclear stress test, you see that most of the time, and this test takes around 3 to 4 hours in most offices all over the world. So in that condition, because most people, because the EKG is abnormal to start with, that a number of things that the doctor can do in terms of stressing the heart. So the doctor can make you walk on a treadmill, and after walking on a treadmill, they will inject you with a radioactive agent, and that is going to they're going to take pictures. I mean, they call it the way people have contrast. They will inject you with a radioactive material, and that will go into the heart to see whilst you are exercising. Because it goes into the blood, it can show us whether blood supply to the heart is reduced or not. That is a very, very important. It's a very important test that we do, and it can not only does it show us that there is a reduction, it can also show us the areas where there is a reduction, because sometimes it can show us whether the reduction is coming from is coming from the blood vessel that is lying on top of the heart, or the blood vessel that is lying in front of the heart, or the blood vessel that is lying on the back part of the heart. So that is a good study to be able to help us. This study has a sensitivity of around 70 to about 80%. Exercise stress test has a sensitivity of about 60-65%, let me put it, at best. So that is where sometimes if doctors are worried, they're going to go to the nuclear stress test. Apart from the nuclear stress test, your doctor can also, if the EKG is abnormal, you can also do another form of stress test where they call it echo stress test, where they're going to make you run on a treadmill. And I really love that kind of test for young women because of the radioactive agent that is given for the nuclear stress test. For young women, I really like the exercise echo, because you can make them run on a treadmill, and once they run on a treadmill, they get the echocardiogram done, and once they get the echocardiogram done, in that situation, it will capture the pictures. And the ultrasound of the heart, if there is a blockage, if the blood supply to any part of the heart is there, once you exercise, you realize that other parts of the body, other parts of the heart will be moving well, and that part of the heart will not be moving well. And that is what we call the echocardiogram stress test. So you can have a nuclear, you can have exercise EKG stress test, you can have radionuclear stress test, you can have an echocardiogram stress test, and sometimes you can even have what we call, there's another agent that we can give to you, we call dobutamine, which we can give to you, and when we give to you, it makes the heart go fast. So people who cannot even exercise, even if you cannot exercise because of arthritis or any condition, you can get the dobutamine echocardiogram, where they will give you an agent is going to move the heart, and as it moves the heart, if there's a blockage in any part of the heart, that part is not going to move well, and it helps the doctors to make a decision whether blood supply to that part of the heart is being compromised. So stress tests is not just one thing. There are various type of stress tests that I've said. So we have the exercise stress test, we have the nuclear stress test, and we have the echo stress test, and we have even the exercise can be added to other ones. So all these form of stress test gives the doctor an idea or tries to confirm whether the chest pain or the symptoms that you are having is coming from reduction of blood supply. Once again, if the test is negative, it does not mean that you don't have plaque in the blood vessels in your heart. It only means that the symptoms that you are having is not due to what? Is not due to reduction of blood supply to the heart as a result of the plaques that is in what? In the coronaries. So let us go to the other one. So the other one that can be used, which I believe that it may soon become the standard, because now when you go to Europe now, especially when you go to England, and now that has become the standard of determining whether there are blockages in the heart, there are blockages in the blood vessels going to the heart. And it makes sense. Why? Because a lot of people who end up coming to the next level I'm going to talk about will realize that they don't have enough blockages in their heart. That should be the cause of their problems. So let us talk about this, which is the coronary, we'll call it the cardiac CTA. You're going to see a picture of it, right? A lot of people see the CT scan, CT scan, CT scan. So a lot of people know CT scan for the chest, but they don't know that there is a CT scan for the heart. So we call it CCTA. Cardiac CTA is important because now, first of all, you see in this picture, you see the camera. So when you lie in the camera, the CT scan machine, this one is focusing on the heart, and that's why you see the picture focusing on the heart. And it takes pictures of the heart, and it can give us a ton of information that will help us to make a decision one way or the other as to what is best for us. That is very, very important thing. So what does it do? The CTA, because it's a 3D system. It can give us an idea. And you see the second picture where you see the blood vessels. It can show us the blood vessels as they lie on top of the heart. You can, yeah. So the first picture that we're going to show you, you see the blood vessels coming alone without the heart. That is the beauty of this technology. So it shows you the blood vessels, and it can pinpoint to us whether there is a blockage in that part or not. So that is it, what we call the 3D reconstruction that can give to us. In addition to that, they can also take the blood vessels and show them slice by slice, and that can show us whether there is what? There is plaque in the coronaries or not. The reason why this test is very important is the fact that if you have a CTA that shows that there is no blood plaques in the coronaries, then it is 99.9% sure that there is no plaque in your coronaries. That is the one you can go to the bank with. I'm repeating this. When you have a cardiac CTA, a 3D cardiac CTA, and the 3D cardiac CTA shows that there is no plaque in your coronaries, then truly there is no plaque in the coronary. It is, in medicine, we never say never, but this is one of the things that is extremely sensitive, because if you have got the minutest amount of plaque there, it is going to pick it up. And that is why the CTA is becoming the standard of finding out whether you've got blockages in your heart or not. So that is what we showed you 3 pictures here. I wanted to lay the emphasis on that so that you will understand what the CTA can do for you, to be able to help you understand why, if the doctor tells you that your CTA shows no coronaries, you can be confident about that. Another thing that the CTA can also do, apart from the giving you the images of the blood vessels themselves and looking through it can look through the blood vessels and see, it can give us an idea of it, is how much calcium is in the blood vessels. And why is that important? Because it is not 100%, but if If he says that the calcium in your coronaries is 0, then the probability that you've got a plaque in your coronaries is almost 0. It's almost 99.9. So that is why the CTA is very, very good, because it gives us a lot of information. It also gives us an idea about how well the heart is pumping. So that has become the standard, the go-to test to find out whether there's a blockage in the heart or not. So let me tell you another thing about the CTA that we don't talk about. So if the CTA, when we do the calcium score, right, the calcium score is very important because, and it comes from doing the calcium score and the CTA. Some people, if your calcium score is 400, that is a sign for trouble. I can tell you that. If your calcium score is 400 and your cholesterol is up, you may be better off taking cholesterol medication. If your calcium score is 800, that is very bad. And that one you really, really, really need to think about. Aggressive medical therapy together with other things to be able to help you. So why is that important? Because why is that important? Let me come back to it. It is important because the calcium score together with your 3D can help us determine not your chronologic age, but your biological age. Why is that important? Because you can have a 45-year-old man that has got a calcium score of about 700. And if you look at the whole coronary, it's going to calculate your what? Your biological age. So the person chronologically may be 45. But if you do your calcium score and do the calculation, then biologically you may be 82. No wonder the person dies early. So now we know that chronological age is not the same as what? The age that we can get from the CTA. And that is what makes the CTA very important. Because if the CTA now is telling us that though you may be 45, but your age is 82, then you need to take steps to address it. Because your heart looks like an 82-year-old or your heart looks like an 90-year-old. The patient that was in his 50s, and the calculation came to like 95. I said, boy, you may have probably 5 years to live. So you need to make some changes in your life. That was very, very bad. I was brutally honest with him that he needs to make certain changes as quickly as possible. And that is the benefit of the CTA. In the cardiac CTA, the advantages that it comes with, which most of the other studies may not be able to do. So there's one thing that we can also talk about. Sometimes before your doctor goes to the stress test, they can do an echocardiogram, plain old echocardiogram without any other thing, and that can give us some information. But that is not a form of stress test to find out coronary artery disease. If they do the echocardiogram and your heart is already weak, definitely we know that the heart is weak, and therefore we need to take it a step further. So these are the tests that generally is done to give us an idea. Sometimes somebody comes to us, and the person comes to us and is complaining of typical chest pain. And the person has got all the other risk factors. What are the risk factors? Diabetes, hypertension, high cholesterol, smoker. He's got everything. And the person tells you, I walk one step, I have chest pain. I rest, I have such a patient that has got classic chest pain. Your doctors may think that, your doctors may think that doing a stress test may not be the ideal thing to do, because there's a probability that the stress test may miss such a person, because the probability of you having the disease is so high. And because the sensitivity of the stress test is about 70 to 80%, and your probability of having it just by listening to you is about 90%, you run the risk of missing it. So the doctors may send you for what? Coronary angiogram. So what is coronary angiogram? You see the doctor in a room, right? And it's almost like a room with an x-ray. And the doctors will go in, put an IV line. I do 99% of my cases through the hand. Some doctors still do it from the groin. I believe that it's all based on your expertise. Personally, I believe that, and it's not personally, it has been proven over and over again, that doing the procedure from the hand is for patient comfort is much better. And I do 90% or 99%. Let me put it this way. It's almost all my patients, I do them from the hand, either from the left or the right, and we go to the heart, and then we'll take a picture. So that is a picture that you see. You see the dye. We'll give you a contrast dye. And the principle about it, we tell people that look at the pipe, right? If your coronary is like a pipe, and you open the pipe, and there's a blockage, what will happen to the water when it gets there? The water will stop. So that is how we know that there's a blockage. So you see the blood vessels, those are the one that the dye is going through. Any place that there's a blockage, the dye will not go through that place. And this is considered probably the gold standard, and which all the other tests have been compared with in terms of whether the blockage that you're having is responsible for the symptoms that you're having. Sometimes people will come in with 40-50%, and there's a test that we can do. We'll call it the FFR or IFR, where it's almost a stress test that we do within the room. And that is probably, in my opinion, that is a true gold standard, because sometimes what the eye sees is not necessarily what is going on. And that one the doctor will perform, and it's done by an interventional cardiologist. The interventional cardiologist will do the FFR or IFR, and that is based on the FAME trials and other trials that we did. And that can show us whether that blockage, it may be 50%, but that 50% may be causing the blockage that you're having. So that is why these tests that the doctor will do are important to tell us. So once again, it can either be a stress test, or it can either be a cardiac CTA. And finally, if your symptoms are so bad and you've got a lot of risk factors, the doctor may opt that instead of just going through this stress test, you may be better off going ahead and getting the coronary angiogram done. So these are the tests that are there, and hopefully that we've been able to explain them to you. Once it is established that you've got coronary artery disease, because once it's established, whether through the stress test, whether through the cardiac CT, whether through the angiogram, the first thing that needs to be done in most people, everybody universally, is the fact that you need to be on medications. I'm repeating this. If there is no river if there is no water in the river, if there is no water in the river, opening the dam is useless. Why am I saying that? The reason why a doctor would like to open the blockage in your heart is the fact that so that the medications that you take, once you take the medications will flow through the blood vessels and go to what? And go to the heart muscles to strengthen them. So that is why medications are paramount. And the major medications that I always tell, and most of the young men, they never had any problem, and they come to us with heart attack, and they ask me, how many medications are you going to take? I said 5. They say 5, and they say for how long? I said for life. Why? Because coronary artery disease doesn't go back. It's a progressive disease. It goes forward. So it's not like you start the medication and you stop. So once you have coronary artery disease, you've got to take your aspirin, number 1. Number 2, you need to take your cholesterol medication. Number 3, you need to take your beta blockers, right? And number 4, your doctor will give you a medication to vasodilate the blood vessels. That is either nitroglycerin or azosorbide. And these are very important, right? And if your heart is a little bit weak, in that case, your doctor will add another medication, either ACE inhibitors or losartan. So these are, at least, these 4 medications, you're going to take them, which is the aspirin, the cholesterol medication, the beta blocker is going to be metoprolol, right? And you're going to have a nitrates to also help you in that situation. If the heart is a little weak, then in that case, you are going to add ACE inhibitors. And that is why prevention is better than cure, right? Because once it's established that you have them, these are medications that you may have to take for life. I will probably, with the beta blocker, there is some data that it is not necessarily for life. But for the aspirin and the cholesterol medication, don't let anybody fool you out there and tell you that you can back off. If at the end of the day, right, whilst you're taking medications, whilst you are taking the medications, your symptoms are still ongoing, then in that case, we'll go to the next one, where the doctor will put in stents. And therefore, you see the picture that is on the screen. There's a blockage on one side, and you see that there's stenting. What does a stenting is? A small mesh that is put in the coronary to open it up so that the blood will flow. Now, the medications that you are taking will flow, and that is going to help you, right? So, generally, if you've got one blockage, you can take medications just for one blockage, and that should be fine. if you don't have a heart attack. If you present to the hospital and you present with heart attack, that may be a different ball game. In that case, the doctor will put in a stent in that situation, and then in addition to that, continue the medication. But generally, if you take medications, and or if you have more than one disease, or you've got heart failure, or the heart function is not appropriate, in those situations, because we have a big trial that came to show us that in people that are totally asymptomatic, it doesn't give you any hope. In people that are symptomatic whilst taking medications, there is a lot of hope. There is no doubt that if you're having chest pain, and the chest pain is coming from blockage in the heart, right, and you have taken the appropriate medications, opening up the blood vessels will not make you live 1 day longer, but it will definitely reduce, that one we know, that it will reduce the pressure or the chest pain that you're having if the pain was coming from the blockage in the heart. Very important point here, because sometimes people said, oh, okay, the stenting doesn't help. It is not true. And that is based even on the ischemia trial that came out recently. People have misinterpreted that. But if you look at the ischemia trial, in people that are having like weekly or daily or monthly chest pain or chest discomfort, in those people, putting the stent in them in addition to their medications will make them will relieve the symptoms that they're having, though you may not live longer. So that is a very important point in those situations. It does not apply to people with heart attack. If you go to the hospital with heart attack and there's a 100% occlusion, you're going to get a stent. In addition to the stent, more importantly, you need to continue the medications. Medications. And a lot of the men, they don't want to take the medications, you know. Certain people, they don't realize it. Sometimes some of these medications, if you are on them, especially the nitroglycerin, for the men, you cannot take Viagra. I want to repeat this. For those ones, you cannot take them, because if you are taking the nitroglycerin and you end up taking the Viagra, that is going to cause some major problems down the road. And so if you are a man that is taking nitroglycerin or nitrates and you're on Viagra, be very careful. And it's important that you discuss with the doctor before you attempt to take them. Now let us go to the other one. If you have more than 2 blockages in your heart, then in that case, your doctor needs to have a discussion with you. You have to take medications. And in addition to the medications, you may need open heart surgery. You look at the picture that we have over there. So in open heart surgery, they'll open the heart and they'll take another blood vessel, a vein from your leg and blood vessels in the chest. And what they do is that they connect it to the heart. They connect it to the blood vessels, they connect it to the aorta, the big blood vessels that blood flows out of the heart. And then they connect it past the area that you have got blockage, so that blood will flow easily. The reason why we call it bypass is that it bypasses the blockage. So what they do is that if you've got a blockage in the middle, it will take another blood vein from the aorta, and then it will go beyond, it will bypass where you have got a blockage, so that now the blood flow to that part that was not getting blood is fixed. Bypass, undoubtedly, if you come out of it, it's a major surgery, but it is surgery that is done competently by most surgeons around the world, and I'm sure in your community. So I tell patients that if I'm going to find more than 2 blockages in your heart, or 2 or more blockages in your heart, if it's just simple blockages that are 2, we'll fix this most of the time without a problem if you came to us with a heart attack, or if you're still having symptoms whilst taking medications. But if you are having more than 2 blockages, I will bring you out of the lab and we'll have a discussion. This is my specialty. This is what I do. I mean, as I said, I do through the hand all the 99% of the time. And in almost 99% of the time, I do it from the hand. And in terms of putting stents in the blood vessels in the heart. But there is a time where we will back off and we'll have a discussion with the patient. And there is something that we call the syntest score. We have a discussion and tell the patient, give you your options. You may be, in this situation, you may be better off going for surgery rather than having a stent, because we know There's trials that have shown that especially in diabetic patients that have got multivessel diseases, open heart surgery may be better for you. Especially if your syntax is already in. Even without a syntax, right? We know that in diabetic patients, clearly, that data was very, very strong. That in diabetic patients with multiple disease is going to help you. So let us summarize this. In summary, if you're having chest pain, if you're having shortness of breath, right? If you're having fatigue that is unusual, it may be a sign of coronary artery disease, which is plaques build up in the blood vessel. And today we've gone through the forms of what diagnostic approaches, which is a stress test or cardiac CTA or coronary angiogram. These are the things that are there. And once that is made, then you need to take your medications. It doesn't start with opening up with what? Opening them up. The first thing that needs to be done with medications, the cornerstone being the aspirin and what? The aspirin and the cholesterol medication. A lot of people, there's a lot of data about aspirin. So a lot of people are stopping their aspirin. If you don't have a blockage in the heart, I don't think aspirin is going to help you from the standpoint of the cardiology. But if you have a blockage in the heart, you've got to take the aspirin. I'm repeating this. If you do not have a blockage in the heart, then I'm not sure. The data that we have now shows that aspirin may not be of a benefit to you. But if you have a blockage in the heart, do not stop your aspirin, because that one is going to be very helpful for you. Your aspirin, your cholesterol medications, and other ones that the doctor is going to give to you. And if your symptoms are not what? Are not going away, or if your heart is already weak, or if you end up with a heart attack, in that situation, then the options in addition to taking the medications will be coronary what? Coronary angioplasty and stenting, which we showed you, and coronary bypass. My hope is that through this program that you're doing, you will engage yourself in preventive activities that will prevent you from ending up at the tail end of it, which is coronary bypass, right? Opening the heart and putting what? And bypass is fantastic if it is done well, and it is done well in most parts of the world. But as there is a saying, an ounce of what? An ounce of prevention is better than a pound of what? A pound of cure. So I believe that you will encourage your friends to watch us. We'll be watching us today, and we'll also come back to you every Tuesday and every Saturday evening at 6 o'clock. Ask your friends who did not join us today to join us again on Tuesday, and I believe that this will go a very long way to help you to understand that even if you're going to go to a cardiologist or somebody like that, this can be something to refresh your mind and give you the opportunity to understand things better so that you can make an informed decision. Once again, thank you for joining me, and thank you to Mr. Blay, who does a fantastic work. This is Dr. Isaac Opoku-Asare. I am an interventional cardiologist and an endovascular guy.